Good morning. My name is Dr. K.V. Chalam. I'm professor and chair of the Retina Services at University of Loma Linda in California, United States. This morning, I'm going to cover an area that is dear and close to my heart, that is visualization of the posterior segment and various lenses we use to maximize the visualization, both for clinical examination as well as for laser procedures. This is my place of work. And coming to the lecture itself, well, what are the goals today? We're trying to see all of retina. So let us start with some fundamental basics. How much of retina is actually there to see? And how do we measure the amount of retina that is visible? What are the factors that influence what we see? How do we overcome the opacities and irregularities of the cornea? How do we overcome the size of the pupil and its influence on what we see? And how do we overcome the spherical shape of retina? It is not a flat surface which you can get one view, and because of the curvature of the eye, how do we overcome, and what kind of utilities we have with the lenses? So how much retina is there? This is around 11.5 to 12.5 square centimeters of retina is wrapped around from the optic nerve to the ora serrata. It is round in shape. More of the retina is on the temporal side than on the nasal side. It is larger in surface area in myops than hyperops. The higher the myop, the larger the surface area. So this is basically an optos wide angle system showing you various parts of the central area, superior temporal, superior nasal, temporal, nasal, inferior, temporal, inferior nasal, and inferior area. This is all what we want to see. And how do we measure? I just want to avoid the confusion of when we say the degrees, visual angle versus the eye angle. Visual angle is the geometrical angle that has been traditionally used for like 100 years, where you measure the angle of seeing from the nodal point of the eye. So the maximum amount of area that is there in retina is only 170 degrees if you measure that way. Commercially, the instrument sellers have used the visual angle where they try to measure the amount of area of the retina they see from the center of the eye. And so in that situation, you have 240 degrees of retina that we are saying that can be seen or measured. So a simple example, so nodal point, that is basically the visual angle, and the center of the eye, the designated by E, is the eye angle. So this is just a, I'm sure everybody that is listening to this webinar will relate to this picture, and we want to see the entire retina starting from ora serrata all the way and in the three-dimensional form. So what are the limiting factors for us to accomplish, and what are we trying to look at? We want to examine the vitreous, any abnormalities. We want to examine the optic nerve, including its elevation, discrete margins. We want to check the macula. We want to check the vasculature and the peripheral retina and the choroid lost in a 360-degree fashion. So those are the components we want to get a glimpse of, so that we can both diagnose and implement the treatment strategies, including laser and other modalities. So like in camera, one of the fundamental problems we have is if the pupil is very, very small, the amount of area that you are going to see is going to be smaller, because any examining instrument is going to throw light in the eye and capture back the image that is illuminated by the observer. As you can see on the left-hand side, you have the undilated pupil. The angle of visualization increases when you dilate the pupil. So this is another three-dimensional illustration. As you can see here, the pupil, the larger it is, the wider it becomes. Undilated pupil, dilated pupil. So what are the medications we commonly use to dilate the pupil? The most effective and fastest is tropicamide, 0.5% to 1%. Phenylephrine, we have to be careful that the patient is not hypertensive. Cyclopentolate, little late in commencement of the dilation, but last longer. Atropine is, cycloplegic that knocks out the iris for a couple of weeks. The optimal effect is usually seen either with tropicamide and phenylephrine 25 to 30 minutes after the administration of the dilating drops. And the larger the dilating diameter, the larger the visualization of the area, logically. And what are the different types of examinations once a pupil is dilated that we can perform in the clinical setting? We can use a slit lamp and both contact and non-contact lenses to get a glimpse of either the macula or the entire retina, depending on the objective of what we really want to accomplish. The second one is basically, or a third one, is the binocular indirect ophthalmoscopy, where you're basically having a lens in between you and the patient, and with the mobility to go around the eye and examine various areas. So in binocular indirect ophthalmoscopy, you get discrete areas of visualization which you have to mentally collimate them together to get the good picture. Whereas on the slit lamp examination, especially with the contact lens, you get a uniform one view. And so that's both advantages and disadvantages of both modalities. So we'll go over one by one and then go through various lenses that can be used. What are the tips and tricks as you do this stuff? So the types of lenses you use, you can have the contact lenses. I haven't put the rest of the lenses that I'm describing here. A direct lens, Goldman's lenses, non-contact, you have convex lenses, 60, 78, and 90. You have concave lens, ruby lens, which we don't use that much often anymore. And of course, indirect binocular indirect ophthalmoscopy, which is 30, 40, 14, and 15 diopter lenses. So let us go back to the simple optics of what actually is happening. So fundamentally, you need to have light that is thrown into the eye, otherwise you can't actually see. The light source then passes through a biconvex lens into the eye, illuminate the entire area. Then the image then is captured back with the binocular lens again between the examiner and the patient. And so there's a fundus picture. So we use the biconvex lenses, and then I'm going to go to the specifics of the advantages of various lenses. So the types of images, so you can get a direct image depending on what you're using, or you can get an indirect image. And often indirect image is, majority of the times is what we get. The direct image, as you can see, is you see the disc and the macula the way it is. In indirect image, you have to compute in your mentally and reverse it backwards for you to administer whatever treatment modalities one may plan. And the second thing is what kind of lens design we want to have. The simple optics is we basically use a biconvex lenses. There is one other simple manufacturing important part that we need to bring into attention, what is called asphericity. So a regular biconvex lens, as you go away from the central point, then tend to have both chromatic and spherical distortion, as you can see, like a barrel shape right here. So if you make it as aspheric, what we mean by that is you're continuously changing the radius of curvature of the front of the lens from center of the lens to the periphery. And so when you do it on both sides, then the distorted image of the spherical nature becomes undistorted. And that's what you really want as much as you possibly can when you're both examining as well as treating the patient. So, how do you obtain the clear image? There are 4 basic components that we want to pay attention to get an optimal view. Obviously, it is examiner. Examiner should be good at knowing the correct working distance, a steady hand and eye coordination, steady hand on the loss, flexibility at the wrist so that you can actually angulate the lens parallel to the pupil at all phases, and the systemic methodology of examining in a sequential fashion and make it secondary image. As far as illumination is concerned, the brighter the intensity, obviously the more you see, but you have to be careful about 2 things. The brighter the intensity, the higher the intolerance of the patient. The brighter the intensity, the more annoying would be the reflections from the lens that you're placing. Because remember, you have the front surface of the lens, back surface of the lens, the corneal surface, and if the patient has an intraocular implant, the intraocular lens. So you have 4 reflecting surfaces coming back at you, unless you are adapted separating the illumination pathway from the observation pathway. The third one is obviously the lens. The more high quality it is, the better. The more aspheric is, the better. And of course, the second part of it is basically the anti-reflection coating. This is basically the coating placed on the surface of both sides of the lens at 1/4 the wavelength. So that way it neutralizes the reflections that are coming on. And lastly, of course, the patient cooperation, the gaze and fixation on, basically responding to the commands of the examiner. And lastly, the corneal surface is the most important thing. It cannot be dry, that impairs the quality of the image that you're getting back. And lastly, pupillary dilation we already mentioned, and of course the clear media. So let us start with the simple thing, which is basically direct ophthalmoscopy. A lot of us carry in your pocket when you're going around for ambulatory examinations. The advantages are it creates an upright image. It's very highly magnification. But the most important disadvantage is its field of view is extremely small. 10 degrees is roughly only a couple of millimeters of retina. Given 12 square centimeters of retina you need to examine, even in the most dilated pupil, you can't really get a large amount of area for the visualization. And stereopsis is not particularly good either. However, it is portable and advantageous in that sense. And this is the optics of the direct ophthalmoscopy. As you can see, this is the patient here. An illumination in your handle is throwing the light, and in a 45-degree angle, put the light into the patient, and the image you're trying to get back through the correcting lens by the examiner here. So the limiting factors are obviously the pupillary dilation here, and of course, the separation of the angle of illumination from the angle of observation that basically gives you the image. So you can examine especially the posterior part of the eye, the disc and the macula are fairly reasonably visualized. But beyond that, it's really a difficult thing to get a good comprehensive view of the retina. So that leads us to indirect ophthalmoscopy, which has become popular since the 1960s. It is an instrument that you carry around, and you have now the batteries are already incorporated so that you don't have to have the boxes to carry anymore. And this is the brightness knob. And of course, it is a binocular. So you can have 2 viewpoints from which you can see. You have the aperture selection. You can also control the size of the light so that you can, in a small pupil, to get the illumination path and examination path separated. So what are the optical principles behind it? It is fairly simple. So you have the observer, you're putting a lens in between and throwing the light. So the area that is illuminated is going to come back and form a clear image between the observer and the patient. And so there are 4 lenses we normally use, commonly practiced as a compromise is usually a 20 diopter lens. You can use a 14 or a 15 diopter lens for higher magnification. But one of the problems is the smaller the diopters, the larger the wavelength on the focal length. So the area for you to hold the lens in the air is not particularly easy. So we normally compromise it with a 20 diopter lens where you only need a 5 centimeter. Normally, when you put your 4 fingers stacked on the top of each other on the forehead of a patient, you're in perfect visualization with the +20. Of course, the +30 is even more easier to hold, but the image size is smaller. And so details may be difficult to view because of that. And then we are going to perform an indirect ophthalmoscopy examination in a systematic fashion. You always start with the superior part, and then at 12 o'clock, you see the superior, then you see the temporal, and then inferior, and then nasal. So make it a routine that you follow this systematic clockwise fashion. So that way no areas are skipped. Remember, we have to comprehend and collimate in our brain what actually is image for us to come to a complete conclusion of the pathology or otherwise. So this is basically a comparison graph showing the field of view that you see on the horizontal and the magnification you see on the vertical meridian. As you can see, a 14 diopter lens gives you a much closer, wider, much magnified view and a smaller field, and 20 is in between, and 40 basically gives the widest field, but the much smaller image size. So these are basically a balancing act. Depending upon what you're trying to look, you may want to choose. But for routine clinical practice, the 20 diopter is a compromise ideal to carry around, unless you have something like a nevus or the choroidal, where you want a magnified view with large stereoscopes, like in 14 diopters. As I already mentioned, one of the fundamental problems with a 14 diopter lens is, you have to hold it in the air and try to have the patient, the lens, and you in a longitudinal fashion, which is sometimes difficult for an untrained person. So the second thing that I mentioned is the annoyance of the reflective, images, because you're going through two surfaces of the lens and the cornea, as well as if somebody has an intraocular lens. So one way is to tilt the lens to avoid the glare. And the second way that is done by the manufacturers are basically the anti-reflective coating on either side. So it neutralizes the illumination coming back. And so that gives you, as you can see, from the left-hand side to the right-hand side, you don't have any reflections. This becomes really important because the more illumination you use, especially if you have media opacities, the higher the reflections are. So one has to be cognizant of those things. So what are the advantages and disadvantages, and how do we perform the indirect ophthalmoscopy? It produces an inverted reverse image. Magnification is 2 to 5, depending on the lens you use. For a 20 diopter lens, it is 3 times the magnification. It is called indirect because you're using a condensing lens in between. The image is formed between the lens and the observer, and the power of the condensing lens determines the magnification. And the stereopsis and wide field of view are the advantages of the indirect ophthalmoscopy compared to the direct ophthalmoscopy. So as a result, larger field of the retina can be viewed. Retina anterior to the equator can be examined. 3D stereoscopic view of the retina and the good depth of focus, and very useful in hazy media, especially if you have a cataract or some mild vitreous hemorrhage. The indirect ophthalmoscopy is, of course, a lot superior to the direct ophthalmoscopy. So what are the lenses? We already mentioned them, so I'm going to one by one. Here is a 20 diopter lens, most commonly used in 90% of the clinical practice. As you can see, one other thing I have not mentioned is the diameter of the lens. In the manufacturing process, higher the lens power, the more difficult to make the aspheric curve. So that's why you see 20 diopter lenses to be larger in diameter than a 28 or a 40 diopter lens because of the manufacturing limitations. So the 20 diopter lens is a double aspheric lens. Magnification is roughly 3 times. Field of view is roughly around 55 to 65 or 60 degrees. Of course, the field of view is also contingent upon the pupil dilation. The larger the dilation, that's why you have the dynamic range rather than just one particular number. So it has to be held roughly 5 centimeters in front of the patient's eye. That's why I was mentioning, if you stack your 4 fingers together and hold it on the forehead, it becomes extremely easy to get a clear image in all directions. The second lens is a 28 diopter lens. The advantages of the 28 diopter lens is extremely useful in pediatric examinations, and also the novices. When one starts the indirect ophthalmoscopy learning, it can be daunting in the beginning to hold a 14 or a 20 diopter lens, and you can't get an image, can't keep it stable. So start with a 28 diopter, which is easier to hold, and also get a much wider view of the retina. And then you can learn the skills until you get adapted the practice of it. So the downside is, of course, the magnification is less. It only magnifies 2.2 roughly. The field of view, however, is larger, 70 degrees, easier to view pathology in the periphery, especially in a postoperative cases or when the patient has air-filled eye. 28 tend to be more user-friendly than a 20 diopter or 14 diopter lens. The 30 diopter is not really that different, 30 and 40, I just put for the comprehensive sake, just a picture of it with the same dimensions. So you, as I already mentioned earlier, you want to perform in a clockwise examination. You need to be also be adapted which hand to use depending upon, which eye you're examining, right hand for the left eye and left hand for the right eye. And you start at 12 o'clock and go in a clockwise fashion. One other thing is you start close and then you bring it towards you until you get an image. And once you get an image, you basically hold on to that and continue the examination. So sequence of how do you go to do about it? Patient should be placed in a reclining chair and recline until patient lies flat parallel to the floor, either in a chair or on the bed. Light beam from indirect lens and the fundus should be in straight line to get a great image. And using the indirect lens, use the posterior pole to examine the optic nerve and macula, and then go to the periphery in various meridians until you get it. I'm also referencing a YouTube video of the American Academy of Ophthalmology, which, I don't have time to go over the video to show you, but those of you that are interested, it is free and you can look at it. It's basically a 5-6 minute video of various phases of examination of indirect ophthalmoscopy. So here is a comprehensive photographs that were taken with indirect ophthalmoscopy with the video. As you can see here, you can see all 6 start in the center, inferior temporal, this is the posterior pole and the superior part of it. So this gives a picture of all the areas you can see, and these photographs were taken with a 28 diopter examining lens. So one other adjunct that I have not mentioned is a scleral depression. As I alluded earlier, retina is a spherical curvature. Viewing up to the equator is fairly easy, and it gets to be a little tricky to do the peripheral retina, which is anterior to the equatorial region. That is where, the scleral depression comes into picture. As you can see on the left-hand side, here is an examination of a normal peripheral retina with scleral depression. On the right-hand side, you already have a scleral buckle with basically scleral depression. So how do you examine the peripheral retina and what are the tricks? One thing you have to be careful is when you are indenting for the scleral depression, you're raising the intraocular pressures anywhere between 40 to 50 millimeters of mercury, which makes it fairly uncomfortable for the patient. So use topical anesthesia prior to the scleral depression. And then be systematic, just like your indirect ophthalmoscopy, and indent above the tarsal plate, and then try to curve the scleral depressor from posterior to anterior to bring the peripheral retina into the view. And that is how you look at it and be systematic. And nasal tend to be a little bit more difficult than the temporal meridian, and superior and inferior tend to be easier for the scleral depression. So here is an example of a horseshoe tear, noted on indirect ophthalmoscopy. As you can see here, the anterior vitreous is pulling a hole and with a horseshoe configuration, as you can see here. And luckily, there isn't much detachment here, so it is amenable to treatment. And so we are doing an indirect ophthalmoscopy-based laser treatment here. So these are the examples of laser. I'm basically focusing on the one on the left-hand side. We're using a binocular indirect ophthalmoscopy laser retinopexy, as you can see here. So identify the pathology on the examination, use indirect lens, preferably a 20 diopter lens so that you have enough magnification with or without scleral depression. Bring the area of interest, adjust the power of the laser, duration of your laser spots, interval in between, so that, if once you're familiar, probably 500 microns is the interval I normally use, and the spot size of the laser is also important. So retinopexy is performed, creating a barrier, especially the anterior part of it is where you really need to be focusing to get a good retinopexy. So here is an example of a freshly done, this is 2 tears here, here is one and here is one. This is a barrier laser retinopexy being performed. And on the right-hand side, you see after 3 months after the laser, as you can see, a chorioretinal scars forming around the retinal tear. So what about the kids, pediatric patients, including NICU? So you want, as you can see in the bottom, the indirect ophthalmoscopy, you can change the size of your illumination, the largest to the smallest. So if your pupil is not really well dilated, you go to a smaller illumination size, large aperture when the pupils are very well dilated. This is an important thing, especially in pediatric patients. So here is an example of an examination in an intensive care unit. We as retinologists are often called to monitor the retinopathy of prematurity. So proper dilation and anesthesia is a key to successful examination of the infants. We use often cyclopentolate, which is a combination 0.5% to 1%, placed 10 minutes apart 3 times to get adequate dilation. And a sterile speculum is placed for each eye, and pediatric depressors are used for examination separate for each eye so that sterility is managed and maintained. So usually 28 diopters is the one that I normally use unless you're specifically trying to look at a particular area for magnification, like a tuft. Adequate positioning with the help of the support staff is important. So without that, it's very difficult to do this. We use pacifiers or oral sucrose for infants because you're obviously depressing, and that can be painful to the child. And careful examination need to be performed. So here is an example of retinopathy of prematurity. You have a plus disease and angiogram showing tuft of new vessels, area of non-perfusion versus perfusion, and in which case we basically do the laser treatment, which is the cartoon here. Basically, the hot laser spots here, a little bit of hemorrhage behind the edge of non-perfusion. As you can see here, it is basically contiguous to each other, and 3 months later, you can see a nice scar formation. So now let's move on to the slit lamp-based contact biomicroscopy. As I mentioned, you have non-contact lenses, and then you have contact lenses. I'll try to describe various lenses we use, the rationality and optics behind them, and then in what clinical situations they are more relevant. So slit lamp stereo biomicroscopy, you can do the starting from the retrolental anterior segment examination, as you can see here, but mostly the anterior to midvitreous as well as retina examination. Here are the examples of the anterior. Then you have the midvitreous cavity, veils in the vitreous cavity, and of course the posterior segment. Depending upon, you can move the slit lamp back and forth, going from anterior to the posterior, as you can see in the right-hand side. You can concentrate on various parts of the retina or the parts of the vitreous cavity. So you don't want to be too close or too far. Obviously, how do you know that? If the peripheral retina is not illuminated, you're too close. And if it is loss of field of view, you hardly see anything, then it is basically you're too far. The correct distance illuminates the entire pupil, and you can get a very precise view of the retina. So that's very important. And especially when you're starting out, this can be a little challenging until you get used to it. It's a classic example of a 90 diopter lens examination. On the left-hand side, you see the disc with a slit illuminating the area. So a patient is positioned appropriately at the slit lamp, illumination angle. This is one important trick, and in this is you try to separate the area of illumination angle from area of observation. Of course, this becomes difficult in a small pupil, but the larger the pupil, the fundus visualization is much better in a reflected light than on direct light. Because if you do coaxial illumination, you may get the view, but the light comes back to you, and the examiner can easily get tired, especially during laser treatment. So try to dilate the pupil and try to keep the illumination angle very separate from the observation angle. The larger the angle, the more comfortable and the more area that you would see. And roughly, you start with a 2 millimeter beam, and the length is 5 to 10 millimeter, depending on the area you observe. And if you have a lot of high reflections, then you try to decrease the size of the illumination and move the slit lamp up and down to be able to see the area. And of course, you have the magnification that is really key of the slit lamp and good optics of the slit lamp. You can do a 10x, 16x, and 40x depending on what slit lamp you're using. This is the greatest advantage of the slit lamp fundus biomicroscopy. So this is a comprehensive optics of the system. Patient's eye, you're putting your contact lens. This is a slit lamp, you're watching it here. So the distance between these two determines the amount of area you're going to see. And I'm going to go into various lenses and the optics of individual lens. So there are usually 4 lenses or 5 lenses are available, starting with a 60 diopter. Roughly remember the dioptric power of a normal human eye is roughly 60 diopters. So image is roughly 1 because of that. And you have a 66, you have a 78, you have a 90. As I mentioned earlier, from a manufacturing point of view, the higher the dioptric power, the more difficult to make the aspheric surface. So you tend to have a small diameters as the power of the lenses go up. 60 diopter lens tend to be larger in diameter than the 90 diopter for that reason. So here again, the cartoon that I mentioned earlier, the field of view you would get versus the magnification. 60 diopter, you get a higher magnification, but the field of view is less. And then this progresses towards the right side, whereas a super pupil lens gives you a very wide view, but your magnification is less. Of course, the magnification can be compensated by your slit lamp. So that's the advantage of the biomicroscopy. So this is a group of lenses I'm talking about. Basically, you have a 60 diopter, a 78, a 90 diopter, a super pupil, and a super field, which is like a 66 diopter. This performed at slit lamp can be performed in dilate or undated pupil. Stereopsis is really good, and field of view is greater than direct and similar to the indirect lens biomicroscopy. Most commonly used is a 90 diopter lens, roughly gives a field of 90 degrees, and magnification is 0.75, around 7 millimeters in front of the patient's eye. So this tends to be a little tricky if somebody has a deep set eyes, so you have to be careful with that. And angulation is very, very important to get a good view. It is a 26 diameter in, roughly in terms of ring to ring measurement. And it's good for dynamic fundoscopy examination because you can also see the periphery. So not only 89 degrees, but when you ask the patient to look below, above, you get a little bit extra of the fundus visualization. So 78 diopter lens, the field of view is wrongly written here. It is 79 degrees, not 97. Sorry for the typo. Magnification is roughly 0.9 and working distance is 8 millimeters. The third one is 60 diopter lens. Obviously, gives you a much wider view, and the diameter of the lens is roughly 31 millimeters. So it gives you a wider field because of that reason. So my favorite lens is basically 130 diopter. We call it a super pupil lens. The advantage of it is you can get a good view even through a very small pupil or in an air-filled eye, or a complicated cataract. This is a good lens for examination. The reason is the amount of the diopters. It gives you roughly around 100 degrees of visualization. Magnification is smaller, but you can use slit lamp to magnify that. Working distance is a little bit closer, but it's good for dynamic fundoscopic examination. Often obviates the need for indirect ophthalmoscopy and saves time. Now, moving on from non-contact to contact biomicroscopy, it's very important for especially in performing the procedures. The contact biomicroscopy eliminates the problems that you may have with the corneal surface. That's really the advantage of contact biomicroscopy. It takes a little longer, but on the other hand, if you want to focus and get the details, especially of the three-dimensional relationships between your vitreous and your retina in various parts of the fundus. So this is the to-go method of choice. Wider angle of visualization, you need a coupling agent like a goniosol or a Kelon. It is stabilization of view during the laser procedures. So it won't allow the movement of the eye, which is really vital when you're doing interventional treatment. The dilated pupil, the larger the dilation, the better the view. The three-dimensional relations are much better visualized with this particular procedure. Again, this is the optics of the system. once we have the contact lens, the images are basically calm as a surgeon or examiner. You basically look at the end of the slit lamp. So where does the image form? Because the contact lens, as you can see, the nodal point, the amount of area you see is much, much wider. And then this collected by the diameter of your second lens of your quadraspheric lens. And then the image forms in front of the lens, which you then capture through your biomicroscope and then visualize that. So the common lens I normally use is basically a 130-degree quadraspheric lens, which has been in use roughly now around almost 25 years. The aspheric surfaces employ high efficiency anti-reflective coating. It eliminates the astigmatism of both the corneal surface and the lens itself. But it does produce an inverted and reverse view image, so you need to get used to that. Like in binocular indirect ophthalmoscopy, the laser spot magnification is roughly 2 times, and the image is half the size of its original, because the lens is roughly around 150 diopters in terms of power. So one way to get around the size of the quadraspheric lens was a high refractive index wide field lens, because you used index of refraction from 1.49 to 1.9 or 2.2. The same 150 diopter lens can be made much smaller in size. So this is a lens that is also, because of the weight, is also reduced. The parameters are more or less the same. It produces 2 times the magnification, 2 times the, and then image is half the size. The next one is a super quad lens. So this is a lens that is particularly used for pan-retinal photocoagulation, because the diameter of the lens is made larger, and that is why you get 160 degrees. However, it is a little bit more bulkier than the quadraspheric lens. While it is mostly useful, you have to be careful in people with deep set eyes. This may be a little bit difficult to hold for a longer period of time during procedures. The next one is a transequator lens. This is it's like a 20 diopter lens for lasers. It is in between the macular lens and the quadraspheric lens. Roughly gives you around 110 degrees of transequator lens. Good for focal laser, inverted and reversed image. So you have to make sure you're not shooting the macula. Laser spot magnification is 1.14 and the image size is 0.7. It has an excellent stereopsis. The macular photocoagulation lens, my favorite is area centralis, 70-degree area. It is 1:1 magnification. So what you're looking at is spot size, laser spot. You don't have to change the spot size because of the lens. And is excellent for macula, especially focal macular laser. Again, the higher the magnification, the higher the height of the lens, which makes it difficult to hold on the lens in perpendicular fashion for a period of long time in the slit lamp area. It's a comparison table of image magnification of area centralis of Volk manufactured ones. Then the main story is the other manufacturer you have. And here is a table basically comparing lens heights. As I said, the larger the height, the more difficult to hold. So we have to be careful about it. The area of the visualization, both static and dynamic. So we are now going into the laser part of it, which is diabetic retinopathy, which is one of the most common things we as retinal surgeons do. You have on the left-hand side is a proliferative diabetic retinopathy with neovascularization. In the center, you have the non-proliferative diabetic retinopathy with macular edema. And of course, in the right-hand side, you have proliferative diabetic retinopathy with some vitreous hemorrhage. So all of them needs obviously laser treatment. So what are the lenses we use and what are the sequence of events we basically do? So I normally use a super quad lens or a transequator, provide the widest field, especially for the posterior pole. When you start, I use a transequator lens because the magnification is better. Then you change it to the super quad lens for the various quadrants. I normally try to do them in 4 sittings. And when I do, I start with the transequator and then change to super quad in the subsequent sittings. Goniosol is used to hold the lens in position. And of course, the biggest advantage is, unlike in binocular indirect ophthalmoscopic laser, Here you have the control of the patient eye movement, so you don't catch the macula inadvertently. And so that's the greatest advantage of this. So here is another cartoon of the after the laser. As you can see, proliferative diabetic retinopathy is a subhyaloid hemorrhage here. And this is the first part of the treatment where you're doing the posterior pole using a transequator lens. So you can see the large dots here. And the last one is basically after the completion of the pan-retinal photocoagulation. How about the macular edema? Macular edema, you need to confirm either with an angiography or with an OCT, like in the middle part of the cartoon here, or in a fundus photograph. Use them as cues. Use especially your fluorescent angiography as a cue to exactly where you want to apply your macular laser, if it is a focal laser, or your fundus photograph, if it is a grid laser, as a guide to doing the laser itself. So the macular laser, as you can see, these are either use an area centralis or transequator for the optimal viewing of the macula. Coniosol is used as a coupling agent. Areas of pathology are identified on the fundus photos or angiogram, and magnification and detailed view of the macula can be altered by the slit lamp magnification that you have, and then focus the laser for a precise delivery of various wavelengths. In the past, before the anti-VEGF agents, we also used to do macular laser for age-related macular degeneration, which we don't do that often. There is still a place sometimes for extramacular neovascular membranes if they're far away from the fovea. The laser can be applied effectively and eliminate the need for prolonged use of the anti-VEGF agents. So I'm coming to the conclusion of my lecture. So what are the lenses I use? I have given you a description of a plethora of varieties of things that are available in the market. I normally use a 20 diopter. This is for the examination part. I use a 20 diopter lens for a routine examination. I use a super pupil XL in the clinic for visualization on the slit lamp. And I use the digital wide field lens for evaluation of the macular pathology because of its advantages in stereopsis and the anti-reflection coating, which is superior. As for the lasers, my 2-go lenses are transequator from the focal macular lasers because it's kind of a compromise between area centralis. The transequator gives good stable view and also protection view so that inadvertently cause any damage to the macula. I use quadraspheric lens for pan-retinal photocoagulation. These are my 2-go lenses. One of the biggest challenges I find is especially when you're starting out, is when you put a quadraspheric or a Rodenstock or a Mainster lens, sometimes it may be very difficult to actually see until you get that initial glimpse of the view. So, you put your slit lamp in a thin beam and a small beam and try to get the glimpse of the fundus. Once you get it, it's very easy to then hold on to that and expand the magnification and examine the various parts and deliver the care that you really need. I think that concludes my lecture. So let us start answering the question. So examination methods along with chart testing inadequately detect early lesions of all types of macular diseases, which require multispectral imaging and central field testing, such as color vision field or resolution under conditions that mimic real world vision. I'm not sure what the question was. Yes, it is true. It is basically a clinical examination. You start with the examination, then you use your clinical examination with various lenses to figure out what's going on. Then you implement various tests to confirm or refute what you thought you saw. And the OCT is routinely used these days to evaluate the macula. And of course, if you have an optos, you can get a wide angle field. And then you also have a sub source that gives you a 26 millimeter cuts to confirm what we thought it is there. So the next question is, describe examination required by emergency room physicians when symptomatic patients present. I would think probably most of them have direct ophthalmoscopy. What you're trying to really realize is before you call the ophthalmologist or whoever is a eye care provider, you're trying to figure out if there's any papillary edema because it can be a systemic manifestation. And direct ophthalmoscopy is what most medical students, at least in the United States, are trained on. And then, of course, once you have the ophthalmology residents or ophthalmologists or optometrists, then they do the examination that we talked about earlier. So the next question is, if I want to purchase only 2 lenses for PRP, which should I purchase? I would probably buy a quadraspheric lens and a transequator lens. Those are my 2-go lenses, because the transequator gives you a great magnification and resolution to start the pan-retinal photocoagulation in the peripapillary and the posterior pole area, followed by quadraspheric lens for laser into the 4 quadrants. The next question was, what is your preferred systemic fundus ophthalmoscopy, posterior pole first or peripheral retina, and which quadrant first? Well, I start always with the posterior pole, because I can then recognize the relationship of vitreous to the disc and the macula. And then after that, I basically go to 12 o'clock, and as I described in the lecture, go in a clockwise fashion. 12 o'clock, starting to the equator and to the periphery. Then, if it is a right eye, it is 3 o'clock next, which is basically the nasal side. Then 6 o'clock, which is the inferior. 9 o'clock, which is the temporal side. That is how I go in a sequential fashion. The next question is, do you do scleral depression directly or through eyelid? I do the scleral depression through the eyelid. Doing it on directly is going to be is extremely painful, especially, of course, during surgery I do directly, but not in the clinic. In the clinical setting, I do through the lid margins and try to avoid the tarsus. So that way, you try to put the scleral depressor perpendicularly above the tarsus or superior and as well as inferior. That gives you, starting from the posterior to the equator to the anterior, and by manipulating away from the globe, you start perpendicular and you manipulate away from the globe. So slowly from equator, it moves to the periphery. And then you do in 4 quadrants, sequentially starting clockwise. The next question is, please when I use 200 micron spot, the effect of laser energy is very poor, and I generally shift to 100 micron scope. Should I use a special lens for better effect? What would you advise for this? Okay, so if you use area centralis, whether it is a 200 micron or 100 micron spot is not the absolute, because is it modified by the lens that you use? For example, if you use a quadraspheric lens, you're half the size, right? So a 200 micron spot on your laser machine becomes roughly 500 microns if you use a quadraspheric lens. If you want to get one-on-one, then you have to use a area centralis, which is basically your 100 micron spot is your 100 micron spot. So if you're not getting laser energy appropriately, there are 3 things you can do. Either you can increase the energy itself, or you can decrease the laser spot size. So depending on the clinical situation, that's what I would do. Do you have any tips for expecting, avoiding, and managing corneal edema in predisposed patients? Very good question. So in these cases, basically use tear drops before you do. It depends upon whether you're doing a non-contact examination or a contact examination. If the patient already had some amount of corneal edema, I would use glycerin drops in the clinic because it desiccates the cornea before you do the examination. And it is extremely useful, especially in patients that may have a high intraocular pressure or a fuchs dystrophy where cornea is already predisposed. So the desiccation with glycerol drops is very useful. Once you do that, then you want to keep your examination to very short time. You don't want to, so you need to be specific exactly what you're looking and try to do it as fast as you possibly can. So the next question is there a standard lens for screening a child for retinopathy of prematurity? And secondly, how easy is to examine the peripheral retina in a child despite a dilate speculum in place during the process of examination? Again, this is variable. My go-to lens is a 28 diopter lens. It's a good compromise between magnification and viewing a large area. So I don't want to spend too much time doing the examination because you already had the patient eye open. You need to make sure the cornea is wetted on a regular basis so that you don't lose the visual ability. So examining the peripheral retina in a child often requires basically a mild scleral depression, and the scleral rigidity tend to be much softer in neonatal situation than in adults, because that your indentation is much more easy to accomplish. So in summary, I basically use a 28 diopter lens. Yes, I do scleral depression to judge the retinopathy of prematurity retina. What are your recommendations for presentation of condensation and pure view in case of a facial mask? Another practical question. I tend to have basically a paper tape placed on the nose of the patient so that the air from the nose doesn't come towards what you're examining. That's what we normally do. In these days, if you have a face mask, put a tape on the top of the face mask so that way the nasal air doesn't come towards the eyes and make it away from the eyes. Which lenses is used for ag capsulotomy? I normally use, again, don't have to use a lens, that's one option. But if you do, I use a lens called a Krieger lens. One thing I have not mentioned here is that is basically a direct ophthalmoscopy lens, which is a flat lens with a shell. So you put a goniosol and you put on it. It gives you a direct image, and you go from anterior to posterior, and it stabilizes the eye so that the eye does not move when you're doing the ag capsulotomy. So it's called a Krieger ag capsulotomy lens. Which lens do you prefer during vitrectomy? The lenses I use a flat lens. This is a question from Afnan Ahmad. So I use a flat lens to start the case. Then I use a miniaturized with SSV XL. That's what the lens I normally prefer. It is a miniaturized quadraspheric lens which allows you the area. We also use a reside non-contact lens depending upon the situation. So to summarize the answer to your question, a flat lens to start the case, a non-contact lens, either a Merlin or a sight, and then for contact, I use an SSV XL. Well, thank you all for the wide participation, and you all have a good day.